My name is Len Wisniewski, Chair of the Board of the Integrative Health Policy Consortium, and it's my honor and privilege to introduce two of our representatives from the state of Colorado, the Honorable Jared Polis and Mike Kaufman. Gentlemen.
Thank you, Len. Thanks, Len. Well, this is exciting. We're excited that Colorado is a real center for integrative health, both on the caregiver side as well as for participation. And this is our inaugural meeting, folks. You were here at the start. We just formed this caucus last year, and I'm excited that we're hosting the inaugural meeting of the Health and Wellness Caucus. I'm excited that you're all here. And as you know, healthcare policy is so important, and we hear from constituents every day about the importance of integrative and complementary therapies and the difference that those have made in their lives. As you know, a lot of us here are spending a lot of time worried about the opioid crisis, which has affected families from urban to rural areas. And frankly, that is one of the timely aspects of the importance of launching the Integrative Health and Wellness Caucus, because one of the areas of focus are alternatives for pain management, whether that's acupuncture, acupressure, medical marijuana, or other ways that people are able to combat pain without having to resort to opioids, because 75% of opioid abuse begins with a prescription. Through this caucus, we are having conversations about how Congress can solve the major health care issues facing our country and better meet the health care needs of everybody, including integrative health and wellness options. So I'm excited about the discussion today. I'm excited to be a co-chair of the caucus, to welcome all of you for the inauguration. I know you're going to go out and help recruit our Democratic and Republican colleagues to have even more members as we continue to grow. Thank you.
Well, it's an honor to be a co-chair with Jared Polis in the Integrative Wellness and Health Caucus. I think it's, when we look at the money that we're spending as a country and the outcomes that we have, they don't add up. And I think that our system of conventional medicine is reactive, and it's not proactive. And I think that the purpose of this caucus is to try to change that paradigm and to focus more on outcomes, more on preventative, more on alternative, and integrating them into the healthcare system, and making our system, changing our system to where it's less reactive and more proactive, and looks at the whole person in terms of health outcomes. And so I'm very excited that we've put this caucus together, and I really look forward to its influence in terms of the Congress of the United States and other policymakers. So I thank you all for being here today, and thanks so much for your leadership in making this happen today. Thank you.
Thank you, Mike. I don't think it's any surprise to any of you that we've got a major problem with healthcare in the United States. When I first went to medical school, I was wondering, just as a freshman, why aren't we studying the healthy? Why aren't we helping individuals achieve their optimal health? And what I learned in medical school was incredibly important. It was how to take care of those who were suffering, who were ill. And at the same time, since I was on the pursuit of health, I started studying the medicine of other cultures and saw that they, as opposed to us, were almost completely focused on health and wellness. So I am very proud to be chair of the Integrative Health Policy Consortium, where that's our mission. Whoops. Our vision is to envision a world where there are no barriers to health, none. No barriers in regard to access, No barriers in regard to the environment. When we talk about the environment, we're not talking about the obvious things we first think about, which are environmental toxins and pollutants. We're also talking about pollutants in terms of relationships, pollutants in terms of the hectic lives that we lead and the effects it has on our immune system and our health. Ecological human pollutants as well. And socioeconomic. We have a group that's part of IHPC that's called I Am For Us, Integrative Medicine for the Underserved. Integrative healthcare, integrative health has been developed over a half a century, believe it or not. We've finally matured to the place where we have evidence, we have an argument, and we are slowly turning the health system around toward wellness and well-being. So those basically is our mission. Our vision. Our mission is to eliminate barriers to health, and that has to do with that prevents people from receiving the services they need or choosing the type of provider they want to promote to maintain health. And this is where I was speaking about I Am For Us, which is one of, I'm sure, other organizations that are focused on the fact that due to the fact that I had mentioned access, and there is relatively poor access to disciplines that are very effective and safe, we now have to have third-party coverage. We're doing plenty of work with, and you'll hear from people in the DoD and VA about what we're hoping to accomplish within those systems, and it's not going to be, hopefully in the future, only a rich person's ability to receive health and wellness services. Our philosophy is that we believe in an integrative healthcare system, an interdisciplinary team, an MD working with an acupuncturist, a massage therapist, a Reiki therapist. When I was at GW doing my residency, we didn't talk about it, but we snuck a Reiki therapist into the cardiac care unit and intensive care unit because we saw the results, but culturally, we did not want to speak about that at that time. It's time to break all barriers to health. Holism and pluralism. We're talking about the body, the emotions, the mind, and the spirit. Not doing a quick examination and reaching for the prescription pad. Sitting with a human being and helping them to achieve their vital and hopefully celebratory life on the journey. Healthy environment, as I indicated. We stand for a U.S. healthcare system based on prevention, wellness, and well-being. We stand for a healthcare system based on health creation. Those are the words of Don Berwick. The Partner for Health organizations, we have grown exponentially in the past several years. We are now approximately 26 organizations strong, with others wishing to join. We represent approximately 600,000 providers, both conventional and I'll use the term integrative or holistic. And we're about integrative. We're not about complementary alternative. We're about integrative. We're talking about the conventional system working alongside with a discipline of thousands of, let's call them, many of them, healers, people who really care. They spread their love, and they work through their discipline for every patient that comes across to them. At IHPC, we've developed a health creation economics pamphlet, which is on our website. Please feel free to download it. It actually compares the costs and shows that it's cost effective to have integrative health. As far as our federal and national initiatives, you know about this one. We also have a National Policy Advisory Council that we're forming, and I'm thrilled to announce that former Senator Tom Harkin has agreed to be the honorary chair. We have a National Policy Congress on Integrative Pain Care. That was initiated by the Academy of Integrative Pain Care. Bob Twillman's the executive director. Bob, could you stand up for a moment, please? This was a historic meeting in San Diego where there were 50 organizations represented and approximately 70 individuals attending. We had representation, as far as the government, we had representation from CMS, DOD, the Veterans Administration, and we had integrative health associations, the American Academy of Family Practice. This was a historic meeting. Everyone was in consensus, and this is about looking for other solutions, not what you're hearing about now, but other solutions which you will hear in the future in regard to this caucus, about solutions to what I call the chronic physical and emotional pain crisis that we're facing. We're facing a crisis of suffering. To talk about the opioid crisis is one slice of the pie, in my mind. We have plenty of other initiatives going as well. And as far as this Congress, there are ongoing task forces formed, and we expect many organizations to join in that effort. It's a pleasure and honor to have had Mike Kaufman and Jared Polis co-sponsor this, and hopefully we will have many members of Congress join to have a rapid access to information, because believe me, we have a lot of information for you. Okay, being in Colorado, I just have to say that we have a superstar lineup of speakers, and the moderator today will be my dear friend Margaret Chesney. Dr. Chesney is a professor of medicine at University of California, San Francisco. She has served as the director of the Osler Center for Integrative Medicine, and she was the first deputy director of the National Institutes of Health, National Center for Complementary and Integrative Health. She has studied the role of stress and burnout on health and developed lifestyle and other health interventions that enables individuals to prevent disease and promote their well-being. She's also a member of the National Academy of Medicine, and Dr. Chesney has been president of 3 organizations. Most recently, she's been president of the Academic Consortium for Integrative Medicine and Health that's made up of approximately 75 of our medical schools. So there is a shift going, as you'll see during this program, throughout almost every stakeholder group. Dr. Chesney?
Thank you so much, Lynn. It's very kind. And I want to welcome all of you. Oh, and she's going to switch my slides. Thank you so much. You're welcome. To this really, really important caucus. And what we're focusing on today is answering this question: what is missing from medicine? And the answer to that is really health. Health is missing. Now, what I'd like to do as I begin is to borrow from an advertisement that some of you may have seen on television, because I think it captures really what we're going to be talking about today. And that is asking you, let's see, oh, we don't have animation stuff. That's good to know. This is an ad that's been out. It says, just imagine, I'm going to let each one of you pick out the car of your choice. So take a minute. What would you, if you could be given any car, what would you choose? And then you would say, wait a minute, what's the catch? And the catch is that this will be the only car that you're ever going to get. So if you're 16 now, this car has to last 70 years But this, you can have that car, and I do have this car in mind for myself. And so what are you going to do? Knowing that it's the only car you're ever going to get, you're going to be thinking about, you know, what kind of oil would you use? What about batteries? Well, I want to get an electric car, so I have to figure out all about where I'm going to get the electricity. I'm going to be thinking about who should I talk to? Who could be the best mechanics to help me with my car? What are the best tires? You would be thinking about this because it's going to be with you for the rest of your life. And I would want manuals. Give me guidebooks. I want to know all the best things that I could be doing to keep that car forever. Well, the truth is, you're not only going to get one car. So we know that. And that's, you know, we know that about cars. But you are only going to get one body and one mind, and it has to last your entire life. And this is true for all of us. One body, one mind. And for many of us, unfortunately, childhood has adverse childhood experiences. And those experiences, as you're going to hear later, set a trajectory for a child. We can tell early on, when children are 9, 10, 11, things that are likely to affect them for the rest of their lives. Lifestyle choices that we make in midlife, even as teens, can create risk factors later for chronic illnesses. Those are just so important. And then, eventually, there are health challenges that people are confronted with, and the clinical care choices that they have, particularly for many of us, they're limited. Those choices will further limit choices, so that all of a sudden, what was once a possibility of a whole health life, that of vibrancy and resilience, is lost, and it can be lost in the earliest years. And then for others, and this is what integrative health and wellness offers, childhood can set a trajectory for health and wellness from here forward. And we don't offer that yet, but it's possible we could have that. Lifestyle choices, those can create resilience so that you could be on that airplane and get exposed to a lot of viruses and not get a cold. And because of the way you live your life, the life choices that you make. And then when health challenges arise, you could have the full spectrum of clinical care options for you. And what we really want to have is where you can have access to a team of experts. And in fact, you should be the captain of that team. You should be the person saying, now that I know that I'm confronted with this choice or this problem, you know, help me get the advice together and then make your decision on how you want your health care. And this is what you can have with integrative health and wellness. And this is the kind of the definition that I think captures this. This integrative health and wellness field emphasizes healthy lifestyles and self-care. It provides information for personalized health-enhancing and disease-preventing strategies, giving people information they can really use, like a consumer's report of how to stay healthy. It focuses on, as actually Representative Kaufman used the term, the whole person, body, mind, and what gives life meaning. For example, I could sprain my ankle, and being someone from San Francisco where we have the Warriors, that doesn't matter so much. But if Steph Curry sprains his ankle, this actually throws our entire city into turmoil. So body, mind, and that what gives our lives meaning actually then characterizes what it means to have an illness, and it can be very important. Then when something occurs, when you need clinical care, integrative health and wellness offers you evidence-informed therapeutic choices, the full menu. And it offers you healthcare professionals and disciplines so that you can achieve optimal health and healing. Right now what we have is if you go into a restaurant, imagine if you're given a menu, but it doesn't have all of the pieces on the menu from which you can choose. That's what we face now. Now you might say, wait a minute, we have the best healthcare in the world. How many of you have heard we have the best healthcare in the world? We hear that a lot. But let's look at life expectancy, and some of you know this story, that basically looking at life expectancy, how long do we live? People in the United States live to, and this was around 2000 and 2014, it used to be 76.6 years. That put us about 37th And Japan is at 81.5 years. So we are not doing that well. And actually 2 days ago, we were compared with the top 11 nations in terms of productivity, the top wealthiest nations in the world. We are number 11th in life expectancy, at the bottom. What did it cost before for Japan to get to that 81.5 years? About $2,000 per person in Japan. It was costing us about $4,500 a little while ago. Flash ahead to this fall, and they reanalyzed all the numbers. Japan went to 83.9. They're still number 1 in the world. And we're down at 78.8 years in life expectancy, just around where Cuba is. And what is it costing? They've increased their cost. It's about to $4,000, and we're close to $10,000 per person. So something is wrong here, and it's affecting all of our lives. We're not doing well. Here's some more facts. We rank number 1 in obesity. 70% of adults in our country are overweight or obese. 70% across the whole country. We rank 33 out of 35 on diabetes, number 1 in drug-related deaths. You've already heard about that. We're number 1 in pharmaceutical spending. And I got this figure from 2 days ago, that the average person, this is the basic per capita cost of drugs in the United States, that's of all people, all the millions of people in our country, $1,443 a year for every single living person in the United States. And we rank number 1 in infant mortality among those top 11 nations. We can do better, especially for that price. In 2009, there was a meeting at the Institute of Medicine that's now called the National Academy of Medicine. They concluded, and you heard the representatives saying this, we have a disease-driven, not healthcare, it's disease-driven approach. Spiraling costs that you've just seen. It's fragmented. It's a fragmented system that's reactive and episodic, as you'll see later in my talk. We react when we get sick, otherwise it's sort of silence. And it's inefficient and it is very impersonal. Now I'm going to take the definition I just gave you and let's look at it against that summary from 2009. With integrative health and wellness, we get an integrated, personalized team approach that focuses on healthy lifestyles and prevention, and it reaffirms this relationship that each one of us should have with a team. And we're going to be hearing from a team of professionals because that's what we should have access to help us in designing an optimal health and well-being for ourselves and our families. Now, we're talking about integrative, and it puts all of these pieces together. We're all familiar. This is not as opposed to conventional. It's the best of conventional medicine, the best of knowing what we should be doing with our lifestyles in eating healthy foods, physical activity, pulling in complementary approaches when they're appropriate, acupuncture, yoga, and now a new something that I see sort of spanning the spectrum that you're going to hear about very soon from the Department of Defense and the Veterans Administration, which is actually doing it, and that is really whole health coaching people so that they can take from any piece of the menu that is best for them at this time, not just to overcome a problem, but to enhance health. Now, what about these complementary approaches to health and wellness? I just want to mention something because there's a lot of interest in those. They've been around for thousands of years in some cases, but how many people use them? Real quickly, this is informative. It was mentioned that I used to be at the National Center for Complementary and Integrative Health, and we did a survey in 2002 and 2007 looking at how many people used these complementary approaches. And actually, we have young kids up there because when I was there, we had no data on young people at all, and we did not know what young people were doing. Grants were coming in on probiotics for kids, and our council was saying, wait a minute, we don't know if that's safe because we don't have any science we don't even know if kids are using yogurt. And I will tell you, I was in the government, so I had to be very polite, but I thought saying, can't we just go look at Safeway? I mean, it's sort of obvious that this is really, everybody's buying it. But so we needed data. I learned, okay, not a problem. I asked for extra money. as they only had money for about 31,000 interviews, and they said, no, we won't give you any more money. But I was acting director, so I said, I have an idea. When you get into a household and randomly sampled and you got some people under 18, ask about it. So they did, and we got data. And what we found was basically from 2002 to 2007, there was an increase. We were close to 38%, about 38.6% of every American in the country, that 38.6% had used integrative medicine in the last year, the last 12 months. And then by 5 years later, it was about 38%, and then 12% were using, children were using something, echinacea, fish oil, they were using it too. So we had the data, and then we could fund the studies on probiotics for children. And what we found in the 2012 survey was similar. Almost half of the people in the country using their own resources are reaching out to make sure they get the full menu. So what about hospitals? It was in 1998, actually, that NCCIH came into being, the National Center for Complementary and Integrative Health, and this is their 20th anniversary this year. And it was about that time we started getting information on hospitals. And in 1998, 8% of hospitals were offering this. And by 2011, it was up to 42%, which is the last time it was measured. Why were 42% of the hospitals offering this? Because of patient demand. This is what the public wants, that 40% of people who want this. And now the Joint Commission has decided, basically as of this year, all of the hospitals have to promote and provide some forms of integrative and non-pharmacologic approaches to pain. So this is all shifting. You're seeing a shift. That 98-99 was a special year. It was also in that year that 8 centers got together. And these were academic health centers. An academic health center is where, like the University of Maryland, that has a school of medicine, also a school of dentistry, the first in the nation, and a school of nursing. So those are academic health centers. And 8 of those around the country said, you know, we're all beginning to look at this integrative medicine. And they formed the Consortium of, Academic Consortium for Integrative Medicine and Health, as we call it, the Consortium. And these 8 centers, that was in 1999, flash forward to now, and over 70 members of academic health centers are now part of this consortium, all looking at integrative medicine and health. And you can look for your alma mater on the list. Just in this area, it's University of Maryland, Johns Hopkins has joined, Georgetown, George Washington, and also entire health systems, including MedStar Health and Innova Health for this region, are all now members because they are focusing on integrative medicine and health in their programs. It's a growing focus. And actually, Len just talked about all the other partner organizations that have joined forces. And these are all now going to be in support of the Congressional Caucus for Integrative Health and Wellness. Now, earlier, I wish I could show this in animation. I can't. We need to try to see if we can get that turned on for others. Typically, if you will, when the way our health system has worked, as people are ill and they come into healthcare, and that is what most of healthcare provides. It moves people not into health, but to neutral. It's like if you have the flu and you go and you get some sort of help from your clinician, and then you no longer have the flu. You're not well, but you're not sick. And that's what we've settled for. But integrative health and wellness thinks healthcare really needs to go to optimal health. We should be helping people be resilient, reduced vulnerability to daily stress, give treatments that promote health as opposed to just being okay. Okay is not good enough for us. So the goal of this caucus and our partnership and all the people you'll be hearing from are people who believe in integrative health and wellness, and we want to go the distance for every single person in this nation, from prenatal health all the way through those last choices that people have to make so that we can have optimal health across the entire lifespan. And so what you're going to be hearing from now is really sort of the forefront of some of that effort, which is occurring actually in the military. The military, I think, is more attuned to looking at a population and saying, we need this population to not just not be sick, but be able to go the distance. So we're going to hear from Eric Schoonmaker and Ben Kligler. Let me introduce both of them, and they can just proceed and speak in order. Dr. Eric Schoonmaker is a retired lieutenant general who served 32 years in active service in the U.S. Army as their Surgeon General, where he was responsible for the health and well-being of really everyone in the Army, and by doing so, also the nation's readiness. And then after Dr. Schoonmaker, Ben Kligler will speak, and he is the National Director of the Integrative Health Coordinating Center of the Office of Patient-Centered Care and Transformation in the Veterans Administration. Before that, he was the Associate Professor of Family and Social Medicine at Albert Einstein College of Medicine, and was the Research Director in doing research on integrative medicine at the Continuum Center for Health and Healing. And he has also been the former chair. He was chair of the consortium before I was. So I'm introducing two really good friends. Eric Schoonmaker will speak first.
So the animation. Well, good afternoon. It's really a privilege and a pleasure to be here today, and we're just working out the fact that there's no animation, so I'll have to get animated up here. It really is a privilege to be here, and I really appreciate the attention of such a distinguished group. Looking around here, I see a lot of friends and colleagues, and I notice that even the folks I work with, a few of them came down here to make sure that I speak the truth. And I'll probably get a grade at the end of this, so really be enthusiastic about what I say, would you? Also, really a privilege to be and pleasure to be here sharing the podium with really leaders in this whole arena. And Margaret has been working very hard during her tenure in the consortium to try to get my community into the consortium. We haven't given up on that. We're still working. And I can't say enough good things about the Veterans Administration and the work that Ben Kligler has been doing, and Tracy Gaudet and Friedhelm Sandbrink and others who have really advanced this whole effort of integrative health, and especially that which applies to pain. So what I'm going to do here for the next few minutes is to take a little bit of a focus away from the whole broad area of health and well-being into one that is not that much narrower, frankly, when it comes to our communities, because there is no complaint that is more frequent or more a problem for patients than is pain. Pain is the number, in the military community, and I think the VA is the same, pain is the number one, number two, or number three complaint of every patient, regardless of why they've come. And if you think about that, and if you're a clinician as well, whether you're in sports medicine or in an orthopedics clinic or family medicine, wherever you are, you probably can mentally reconstruct the fact that the patients that you come to see in the main, if not in totality, are coming to you because they're in pain in some way, shape, or form, and are trying to work through that. And what I'm going to talk to you, and I think Ben's going to also touch on it, is what we in the federal medical community, especially the VA and the DoD, are doing to try to advance the use of integrated practices. Now, I was really pleased that the congressman helped me. Normally when I give this talk, I usually start off with a picture of a cholera epidemic victim being resuscitated somewhere where cholera is raging, with fluids, is being cared for this life-threatening diarrhea that results from it, and antibiotics at some point. But you don't treat cholera by just treating victims. You go back, as one of the fathers of epidemiology, John Snow, did in 1853 in London, an anesthesiologist himself who studied the epidemiology of where cholera victims were emerging from London and realized that they were clustering around the so-called Broad Street pump. And when he took the handle literally off the Broad Street pump, the epidemic stopped. Why? Because some mother had washed a diaper contaminated with cholera in a small depression in the street near the pump. It infected the water supply, and people then transmitted cholera. We are not in an epidemic of opioid addiction. We're in an epidemic of epidemics. And as one of the congressmen said, the epidemic begins with the epidemic of poorly managed pain in over 2/3 to 3/4 of the patients. So the diversion, overuse, misuse, ultimately opioid use disorder and addiction of the majority of our patients begins with pain management. And whether it's a 93-year-old woman who had a hip replacement, whose daughter I sat next to on a plane going to San Diego to the meeting that was alluded to earlier that Bob was at and Len, where her mother, over the course of 6 weeks of recovering from her joint replacement, got addicted to OxyContin. Why? Because she was given a handful of OxyContin by her doc, and she was told, take this OxyContin every 6 hours for as long as you need it. And 6 weeks later, she's addicted. She's 93 years old, and this 65-year-old daughter has to go out and put her through cold turkey recovery. There is no program that she could afford to put her into, and there's no, except for a street program of street addicts and drug users in the San Diego area. She couldn't afford to put them in a high-cost drug rehabilitation program. So she said, the worst experience of my life was taking my 93-year-old mother through drug withdrawal from opioids over the course of the weeks that followed. And that's not an isolated event. That was a random stranger I sat to next to the plane. And I know Delta has figured out how to put me in the middle aisle, the middle seat, but they're not so smart to figure out how to put us next to people that are suffering from what we are studying. That event and that encounter is so common for us right now. So I'm going to talk about what we've done in the military, and quite frankly, I labeled this as the military and the VA because the VA is now leading the nation, in my view, in this effort, and needs to be commended for the work they're doing. Both Tracy Gaudet and Ben and many others. It's a really phenomenal thing. These images, I hope you stick, regardless of whether you remember what I say. But the images that I couldn't have put up 10 years ago of a soldier doing yoga, we couldn't even call it yoga. It was combat movement. But now that we know there's good evidence for these things, people are very accepting. And I'm privileged to work in a community, quite frankly, that our surveys every 2 years of use of these has shown that the military community is actually very receptive. Whether that's because, as the cynics say, that we frustrated them by not giving them treatments that work for them, or whether it's because many service members are stationed in foreign environments where they learn this. My own wife learned about integrative practices from a German acupuncturist on our second tour in Germany, or they marry a Korean, or they're assigned to Japan. But for whatever reason, they're far more receptive to the use of integrative practices than probably any other community. And now we're tracking that, and it's a remarkable experience for them. Real quickly, I'm doing this in my private capacity. I have to acknowledge the fact that my wife is a mindfulness meditation and yoga instructor. I don't know who speaks for the DOD in the U.S. and my university, but it certainly is not me. So there's no animation here, but all this is showing you is most of you are aware of the fact that we are experiencing unprecedented survival from battlefield wounds. If we tell a soldier, a Marine, an airman, a sailor, a Coast Guardsman, if you are injured in combat now and survive the initial wounding experience, the likelihood that you will survive treatment and recovery and rehabilitation is over 95%. That's an unprecedented, and we've done that through all of the efforts here, from better training and better equipped medics to soldiers themselves who know how to put a tourniquet on, as we've taught the people that treated then at the Boston Marathon bombing and others. Right back to evacuation. The Air Force has now put literally intensive care units in the air. We can put a soldier who's lost 4 limbs and half his blood volume on a plane within 10 hours after getting injured and flown back to the United States in an intensive care unit inside a C-17. That has never been achieved before. And frankly, the Air Force was able to do that for the first 50,000 wounds and injuries and illnesses of these wars. 50,000 patients moved. They did not lose a single patient, despite the intensity of their wounds and the care. So it's just remarkable achievements. And then the rehabilitation. That soldier in the middle down there is actually a soldier we retained on active duty with 2 amputations. He became one of my non-commissioned officers that helped run our rehabilitative centers. I plucked him off the 2nd story of a climbing wall that we had at Walter Reed. He had adapted his prostheses to be able to climb the wall, something that I don't have the courage to do, quite frankly. And thank you for that reminder, Margaret, that we're all a little bit overweight. I am not going to hit the slider bar afterwards. So here's the pain challenge that we have. And I labeled this as that the military is the gateway into the Veterans Administration. Ben and I were just talking about this. We need to develop within the military the expectations and the processes and the orientation of our active duty that they can expect to see within the Veterans Administration, and so that we're one continuous, even though we're 2 executive branches with 2 different cabinet secretaries and 2 different budgets, we really need to build, continuous programs of health and well-being. And what you see here is that veterans and soldiers, and I'm a soldier, so I'll say soldiers instead of having to say each time soldiers, sailors, airmen, Marine, Coast Guardsmen, but I mean that. All service members experience more pain on average, and that appears to be even more so for women veterans. Remind you that between the VA and the DoD, we manage about 20 million patients. In fact, when we were out at the meeting that we talked about earlier, Bob, I think we counted the fact that the groups represented from Aetna to the military to the VA and others represented, 60 to 80 million Americans. We were talking about close to 1/5 to 1/6 of the whole population of the United States represented in these integrative efforts. And it's very important to realize that relative to the population at large, our patients experience far more pain. As you can see, it's musculoskeletal pain. And why is that? We all know about the combat wounds, and we can expect that someone who's lost a limb or had a severe, grievous injury to an extremity, and for every amputation, by the way, we have 7 times as many just grievously injured extremity wounds. The fact is that service in uniform is a contact sport. And what you see here, don't get caught up in the words. What was that, this? Okay. But look at the kind of the melody of this. And that is, relative to everything else across the first decade of the 21st century, kidney disease, cancer, cardiovascular disease, renal disease, which remain pretty flat. The 2 lines you see are behavioral health and musculoskeletal injuries presenting at outpatient clinics. And this is real data for across all of the services. So we say that if you're a 35-year-old light infantryman or Marine whose average basic load is 120 pounds and you're working at 8,000 feet and you're running 12 miles with a pack and a weapon, by the time you're 35, you've got a 65-year-old neck and a 65-year-old knee, and your back is shot. And that's what we're seeing here, is musculoskeletal injuries. So it's not wounds per se. The other thing we know is that pain, especially chronic pain, which is different than acute pain, and if we get a chance we can talk about that, once pain becomes chronified after 6 weeks to 3 months, it's no longer about tissue injury and nociceptive problems with nerves. It's a brain disease. And it's unique to every individual that revolves around your emotionality and revolves around your memory of pain, and with overlays of how your brain thinks of pain and the rational construct. And so these mind-body practices are very appropriate because they're probably interacting and interfering and redirecting parts of the brain in ways that we don't still understand. Very important is chronic pain very rarely in our population, and this comes from the VA, but it's overlapped with what we know in the active component, is very rarely a solo problem. It's usually in an interaction with a concussive brain injury, with depression, with post-traumatic stress disorder, with an alcohol drug problem, with other things. So it's a complex array, and we have to approach that as a biopsychosocial construct that, quite frankly, early pain centers like John Vaneka's Center out at the University of Washington also recognized and began to work on. And we've fallen off the curve of doing that. You all know this, that whereas in the 70s and 80s we were facing epidemics of these drugs and the use of these drugs that were restricted to cloistered areas, often of inner cities and selective ethnicities. Now we're facing an increasing rate of the use of of prescription opioids that have led to an unprecedented death. This is the most serious health threat to this nation that we've suffered in 240 years. This will exceed the impact of the 1919 Spanish flu epidemic. It killed 20 million people, 30 million people worldwide, but that happened in a year. It took people out. It killed half of all the people who died in World War I from non-combat wounds with Spanish flu, but it was over in a year and was gone. What we see now is an epidemic of epidemics, with pain leading to opioid use, leading to hepatitis C epidemics where unsafe needle practices are used, to the loss of human potential. Parts of the country that have less than 4% unemployment, but they can't employ anybody because they have a positive urine test, or they're a felon, or they're incarcerated. So now we've lost that. And now, for the first last 2 years, we've seen declines in life expectancy that are directly attributable to this problem. And we aren't spared from this. We saw that. What we did is I stood up a task force called the Pain Management Task Force in around 2008, 2009. I said to them, look, based upon experiences of my wife and other patients of ours that I've seen, you need to open the aperture to integrative practices that are evidence-based. And to their credit, they came back, including Trip Buckenmeyer, Dr. Buckenmeyer, who helped lead this, and is himself an anesthesiologist and a proceduralist, says, you know what, I didn't realize this, but there's better evidence for the use of acupuncture, yoga, chiropractic, guided imagery, mindfulness meditation than there ever has been for chronic opioids. In fact, what is the evidence for the use of chronic opioids in chronic pain? None. None. There are no reputable scientific studies that show that chronic opioids in chronic pain work. In fact, there's lots of evidence that it causes huge damage, and even evidence that it may make pain worse in some patients. And yet the evidence for these practices are out there in abundance. Institute of Medicine, now the National Academy, followed a year later with their own larger study for the whole nation, pretty much overlapped. And what we saw at that time was the acupuncture, biofeedback, and yoga and meditation. Now we've expanded that to these music therapy actually has very good literature, mindfulness meditation, medical massage, Tai Chi, probably for cervical pain, the movement therapies. These all have good scientific literature and research behind them. This is to show you the coordination of the federal system in this regard. In the middle is a timeline from 2008, 2009 up to the present, and what you see there is the VA led, DOD followed. We put together consolidated products that are at the bottom here, Institute of Medicine study with the IOM report on pain in America. And then the NIH's Interagency Pain Research Coordinating Council was tasked after the IOM report by the Secretary of HHS to come up with a national pain strategy, which is under that star there. And that group put it together, published it. The National Center of Integrative Health then brought together the VA and the DOD. We now have a platform for doing research in integrative health that's been very successful. A couple of things real quickly, and I'm going to get the hook. If we can do one thing in this world that will transform it, it's adopting this way of measuring pain. We got into our problem in part because we were asking every patient, you've been to the hospital, the custodian asks you if you're in pain, the guard asks you if you're in pain, the clerk asks you if you're in pain, doc asks. We started chasing zero, as Jane Valentine says. This tool is that analog scale, but it adds functional interruption, and it asks, how is the pain interfering with your life? Sleep, mood, stress, activity. And when you ask patients that, it changes the whole way we go after this to one that's functionally based. We also have other tools. Last slide, and then I'll quit. The Samueli Institute helped us with this. These are the 4 quadrants that we feel are very, very important to attack in policy. In order to have an effective integrative program, you, number one, have to have an integrative care delivery system that's multimodal, that's multidisciplinary, that's team-based, and that's focused on patients. You need to get patients involved. You can't have patients passively looking to the system to inspire them to make things better. We need to engage pediatric populations and sports teams. You need operations within the health system that support it, and most important, you need a sustainable business model. The reason this is not being done, even though we know it works better, is there is no business model that supports this. So with that, I'm going to step down and say thank you very much. And Ben?
Okay. If everyone wouldn't mind sitting back down, we did finally manage the slides. And there's so much to say. I want to thank General Schoonmaker, because that was just a perfect setup for what I want to talk about, which is really the... so there are two ways to look at this field. There's a way to look at it that has to do with the modalities that we can offer people, things like acupuncture, chiropractic, massage, tai chi. And then there's a way to look at it which is really about the, quote, transformation that we're talking about, which is about bringing control and access to and decision-making power over health back to the person and making that the focus of the care. And that's really where the transformation comes in. So what's been motivating us in the VA is really the fact that that's what we're working towards, and the complementary and integrative health modalities, which I'm going to talk about at the end of my time briefly, are really in service of that. So I'm going to talk to you about the whole health model that we're moving forward in VA as kind of a manifestation of what that transformation can look like. So just a quick rundown on the VA for people that are not familiar. Largest federal healthcare system in the U.S., I think bigger than the DoD, but I could be wrong. We have 18 VISNs, which are the regional networks that the VA is divided into. It's 150 plus medical centers, about 1,000 or a little bit more outpatient facilities. There are 9 million patients enrolled in the VA. Roughly 6 million of those are in active care, and there are 330,000 staff. So this is a big organization. So what is whole health? This is our definition that we're using of whole health, and I'm going to say more about it. Whole health is an approach to healthcare that empowers and equips people to take charge of their health and well-being and live life to their fullest. And what we like to say, our boss, Tracy Godet, who's been a great spokesperson for this, and we didn't invent this, but it's about changing the focus from what is the matter with you to what matters to you. And that's what your healthcare should revolve around. And if you just keep that in your mind, that's kind of a core organizing principle around what we're trying to do. So let me talk for a minute about this whole health system, which is the sort of operating system that we're trying to help install in the VA as the way to further this type of approach in the care of our veterans. So there are 3 components. I'm going to put this slide up again in a second, so I'm going to skip to the next one, which actually defines the components for you. The pathway is an experience that is not conventionally part of our approach to healthcare because it's non-clinical. So the idea of the pathway, which is ideally where veterans can start in this whole health experience, is that you engage in a conversation with a peer, not a clinical conversation, a partnership conversation, where you get to talk about what matters to you in your life. You get to do something called a personal health inventory. Start on your personal health plan. Think not necessarily about your problems, but also about your strengths, what makes you well, what makes you healthy. And then you get to start to think about what tools you might have to mobilize. So that's the pathway. That can happen in groups. It can happen individually. We're working on setting it up so it can happen online for veterans in rural areas who may not want to come into the facility. So then the second part of the system is what we're calling the well-being program. And this is where some of those tools that the veteran may want to use for advancing their health around what matters to them, this is where the facility can offer these tools. So these would be things like acupuncture, tai chi classes, whole health coaching, many different kinds of integrated modalities, and I'll talk about that a bit at the end. So this is a well-being program. Some of this is happening in the VA facility. Some is happening out in the community. And the third part of the system is whole health clinical care, and this is in some ways the most challenging. This is where we help the physicians and the wonderful practitioners who were trained in a conventional model of care where they're very disease-oriented, and a visit with a patient is about checking off the plan for each diagnosis, which we all, I mean, I'm a physician and I was trained that way, so I think many of us recognize the value of that. But we're turning that on its head and thinking about how to organize our clinical care around what matters to the veteran and around what their personal goals are for their health. So that's another aspect of our work, is really working on training those 330,000 employees in the VA so that everybody understands what that means to orient care around what matters to the veteran. So just to take a look at this again, you can see now how these circles all overlap, and each of them by itself isn't quite enough. So it's not quite enough to offer acupuncture by itself. It's not quite enough to offer clinical care by itself, even if it's whole health-ish. The pathway by itself doesn't address the diseases that people are struggling with. So the idea is we need all three parts of this system. And what you see in the middle is personal health planning, and this is where the veteran is working consistently with peers as well as with their clinical team to identify what matters to them and how to organize their care around that. So just to break that right down, what that might be is, what's important to you? This comes up in a conversation with a veteran and a peer. Well, I want to be able to get out and walk and spend time with my grandkids. It's not that what's important to me the most is getting my hemoglobin A1C down or my blood pressure down. It's to do those things because I will be more healthy and I will be able to do the things that I want in my life. So in a nutshell, that's kind of where the difference lies between the two. So just a quick little history. This has not been an overnight transformation in the VA. This is something that's been going on. This goes back 6 years. It's really been going on more time than that. But let's just say quickly, starting in 2012, the VA strategic plan defined the #1 strategic goal, and these are great words: provide veterans personalized, proactive, and patient-driven care. And this has been sort of the mantra in VA of this period of time. So they defined that as the goal. How exactly we would get there wasn't so well defined. So our office and many other offices were charged with sort of get out there and figure this out. We funded a number of centers of innovation. In 2015, the then secretary actually identified whole health as the VA's approach to delivering this kind of personalized care, sort of the delivery system. That gave a lot of momentum to the spread of this across the system. We were able to fund in a number of design sites around the country, and then came the CARA legislation, which I'm going to talk about more in a second. So this is just a map of some of the design sites where we funded modest programs to sort of have a VA facility be able to experiment. Well, what is it like to bring coaching into the facility? What is it like to try to have a peer-led conversation group with veterans about what matters to them? What is it like to try to retrain your clinical staff so that they think about these whole health principles? So we've been getting a lot of experience with this across the system in the last 5 years or so. So then this was a huge development, and this is, it's funny to be talking about this here, because normally when I give this talk, I say, that expression where it says, it would take an act of Congress to change something. So we had an act of Congress. And this is the Comprehensive Addiction and Recovery Act. This was passed and signed into law in July of 2016. And it's not all about complementary integrative health or health. Most of it is about pain care, addiction care, addressing the opioid epidemic. And it's aimed at VA, but also at DOD and at other parts of the federal government. So it's very wide in its scope. But there are two parts of it that really were directed at us in the VA, which have really provided a huge amount of momentum for us in this effort. So the first, Section 932. Whoever thought I would get excited about a section of a legislation, but I know it by heart. Section 932. So this charged the VA with developing a plan for expanding research, education, and delivery of clinical care in the area of complementary integrative health to veterans. And so this was a plan that we worked on a lot over the end of last year, and it was signed by the secretary in March of 2017. So we have a blueprint now for how VA is moving forward with increasing training for staff, increasing access to clinical care, and increasing its investment in research in this area. And that plan is really guiding our movement and our decision making. Then another part of the CARA Act, which is Section 933, mandated that VA stand up 15 pilot sites to look at the integration of complementary integrative health into the care of veterans, particularly with an emphasis on pain care, on mental health issues, and on well-being in general. So this was a mandate from Congress to set up 15 three-year demonstration programs around the country, evaluate them, and then report back to Congress about what is the outcome of bringing more integrative health to veterans. This is a very influential piece of legislation, just tucked away in a bill, just one little section, but this is having a huge impact on the VA. So what happened then? So based on this legislation, we have a mandate from Congress, we have to do this. So our VISN directors, who really control many things in the VA, including the flow of funding to their VISNs and a lot of decision-making about priorities, they decided not only were we going to do 15, but because there are 18 visits and nobody wanted to be last to the party, they said we're going to do 18. So we have now identified 18 whole health demonstration sites that began their work in the beginning of this fiscal year, so in October of 2017. And their mandate, their job, is to fully implement this whole health system, all three parts of the system, over the course of the coming 3 years, and basically help us measure what is the impact. What is the impact on veteran-reported well-being around things like pain, quality of life, engagement, function? What's the impact on disease-oriented outcomes? So are we improving people's blood pressure and weight, et cetera, their diabetes? What's the impact on cost and utilization in the VA, and what's the impact on staff engagement and staff satisfaction of staff working in this model? So these 18 sites are working together with us in a very large experiment to look at what's the impact of bringing integrative health and whole health more fully out to a large number of veterans. And the goal is, over the course of this 3 years, that we touch 30% of the veterans at each of these 18 sites with some aspect of the whole health model. And if you add it up, that's a lot of people. So a typical large veteran center might have 100,000 unique patients, and we're talking about actively touching 30,000 of those patients and then multiply that out across the country. So really exciting opportunity. So just FYI, these are the 18 sites around the country. I will say Washington, D.C. is thankfully not one of them, if people have been following the papers. So, but there are many wonderful sites, Tampa, Atlanta, many of these sites really leading the way around how to bring this out into clinical care. So this is a great opportunity. There are a lot of challenges. There are a lot of competing priorities in VA. People are wanting to continue to be able to deliver quality primary care while they're delivering some of these new services. There's a new executive order that mandates that we expand mental health access across the VA to recently separated service people. So really a lot of challenges, but at the same time, there's a pretty strong conviction at the VA, really even up to Secretary Shulkin, that whole health is one of the things that VA can do that private sector can't do. It's one of the things that can really distinguish VA. Was that 5, Kelly? Okay, got it. So we really have a lot of momentum, and to be honest, it seems quite strong and solid. And what's great, too, is this is not a new thing in VA. VA has been moving in this direction of more patient-centered, patient-driven care for 6, 8, even more years. They've also been moving towards the medical home model that plans out a team function that says, you know, one physician, one patient is not the model anymore. So there are a lot of things that have been happening in VA over the last decade that really build toward this model and we think are going to really help it be successful. So in the last couple of minutes I do want to shift away from talking about whole health and that larger approach and talk specifically about integrative health approaches and modalities. And this is the work of my office. We're called the Integrative Health Coordinating Center. So we're a subunit within the Office of Patient-Centered Care. And our job is specifically to try to move forward access to complementary and integrative health modalities for veterans across the country. So obviously not just at these 18 flagship sites, but really across the country as a whole. And our job is also to help support education of staff and help support the movement of the VA's research agenda forward in this area. So once again, whoever knew I'd get excited about memos and directives. I was a clinician in the academic medicine world for 25 years, but I am. So in May of 2017, VA passed what's called a policy directive. And so this policy directive, again, is having a huge impact on VA care. This was in the works for a number of years because, as you'll see, it really pushes the envelope quite actively as far as what VA is offering. And basically what this policy directive says is that complementary integrative health approaches with evidence of promising or potential benefit must be provided to veterans as part of the standard medical benefits package. So this is, I'm just going to say it again, we sometimes still are stunned ourselves, 2 minutes. VA, as a health system, has committed to cover the promising, evidence-based, integrative health approaches, where appropriate, for the entire patient population. So this is a step that VA has taken that really, in my thinking, no other large health system has taken on this scale. So what are we talking about? That we have a system in place that's laid out by that policy directive for vetting the complementary integrative health approaches, and basically, do they pass the bar for published evidence of effectiveness? We're an evidence-based system, so in order to become widely deployed as part of standard medical care in the VA, a therapy has to really have proven itself. So these are the therapies to date that have passed that bar and that are now being offered as part of standard medical benefits to veterans, where appropriate, as part of their conversation with the treatment team. And so you can see the list. I won't read it. I do want to note that chiropractic has been offered to veterans as a standard of care for over 10 years, and that was by a specific mandate from Congress in the mid-2000s. So we don't count chiropractic under our umbrella, but that's another integrative approach that's being widely rolled out to veterans. 1 minute. Okay, so this is big news, and it's not unchallenging. VA is working hard to figure out how to actually offer these things. Particularly, you have rural populations, you have parts of the country where people are just not perhaps familiar with Tai Chi. We had one facility director say, my veterans want to go hunting and fishing for their relaxation therapy as opposed to learn Tai Chi. Do I really need to offer them Tai Chi? And we said, well, you know, maybe you want to offer both, or maybe you want to do Tai Chi while they're out hunting and fishing. So, and you know, Tai Chi is evidence-based, hunting and fishing not yet. So, this is really exciting from our point of view, and we think this is a really amazing opportunity because we're also strongly connected with the Office of Research and Development and the Health Services research community within VA. So we have an opportunity to really do some meaningful research looking at the impact of these therapies being more widely available to the veteran population. Focusing on pain, focusing on mental health, but also focusing on well-being and quality of life. So I just wanted to end with a revisit of this slide to just make the point again that this is not about substituting acupuncture for opioids in the treatment of pain. It's really about, as Eric was saying, helping reorient the care around what's important to the person, and really around the person as opposed to the disease. The integrative health approaches are in service of that. They're super important tools, and thankfully we now have those in our toolbox in the VA. And we're really hoping that this model will become a model that, you know, the whole country wants to look at and that we can really learn from in terms of its potential impact. I think I'm done.
Go ahead and get ready. And now what we're going to do is actually give you a chance to kind of see how the team would work together. So you're going to hear from Ben, and then part of the team will be hearing from acupuncture, chiropractic, and naturopathic experts. Thanks, Ben.
Okay. Great. Okay, well, if you thought I talked fast on that last part, wait for this part, because I only have 5 minutes. Luckily, in New York, we know how to talk fast. So basically, I think our main purpose on this panel is to illustrate the degree to which integrative health and whole health is really a team sport. It's not something that the physician does alone. It's not something the nurse or the acupuncturist does alone. It's something we all have to do together. And so I'm going to just share a couple of examples of VA programs that really illustrate that, and I actually have some data that's accumulating of really successful outcomes, just so that you see how we're approaching it in the VA. A really core part of this whole concept is that this is care that has to be delivered by a team. So the two examples I'm going to give, the first one is from Atlanta and one is from Tampa. The first is the Empower Veterans Program, or we call it EVP, Intensive Whole Health Coaching for Veterans with High Impact Chronic Pain. This is specifically a pain program, but it really aims at the whole person. So it aims at the pain and the person's experience of pain. And the lead on this is a wonderful guy named Michael Sanger, who's been really leading the charge on this in Atlanta and is now working on spreading this to a number of the sites around the country. And so what is EVP? It's a 10-week group-oriented program, 30 hours total, and it includes 3 different approaches. So there's this whole health kind of coaching or reorientation approach, and that goes along with mindfulness training. There's acceptance and commitment therapy, which people may or not be aware of. It's a very powerful sort of modification of cognitive behavioral therapy that really focuses around values and what's important to the patient as part of the core healing. And then there's a mindful movement component. And basically, every time veterans get together, and this is just half the course, but I thought I'd show you, they have a 3-hour experience that includes all 3 of these approaches. So they move, they talk to each other, they practice mindfulness. And every time they do it, they come back for 10 weeks running, and they experience each of those things. People are referred into this. This really looks to serve a pretty intensely in-need population. It's a pretty intensive approach. If you think about committing yourself to 3 hours a week for 10 weeks, it's a big commitment. So a lot of the guys in this are really significantly disabled on significant opioids or other medications and really ready for the help. So this is not sort of the whole health light that just everybody participates in. So they've done some great research. They've had over almost 400 graduates, I think over 400 now, and they've done before and after estimates. They've shown improved quality of life, less depression, less pain interference, which is what General Schoonmaker was talking about regarding the impact of pain on your life, not just 0 to 10, but what is it doing to your life, improved mobility, etc. They haven't been able to look yet at the impact on opioid use, but at least preliminary data suggests that people going through EVP are ending up with significantly less opioid use. And the concept is the pain is no longer in control. So just to show you a few slides, and we don't have to go into this in detail, this is a measure on the right-hand side of your slide. There is pain interference. These are what's called effect size. So delta, I can't remember, it's, who's D effect? Cohen's D. Is that the right? Yeah. So this is the size of the effect, and anything over 0.3 is a pretty significant effect. And you can see that the change from before to after in the impact that pain is having on people's activities, social life, work, etc., quite a significant effect before and after EVP. Also looked at pain acceptance, which is sort of in the same category, and you can see the change before to after, also significant. Quality of life. There's a questionnaire they use about depression, and obviously, as you know, suicide prevention and activist treatment of depression, a huge priority in VA now, so significant improvement on depression. And then one of the questions on the PHQ-9 is actually about suicidal thinking, and also a significant decline in that from before to after the program. And this is just to give it a face in one person. I can't unblow myself up, but I can change little things. And before you know it, chronic pain goes from pretty much the #1 thing to something that's just kind of in the background. So it's not about getting to 0 on the pain scale. It's about, you might stay at 6 or 5 or 8 or 4, but it's in the background. I have a life, I have new skills, I have a way to make this, bring meaning back into my life, even while I have the pain. So this is just one example, and you saw the team there, chaplain, social worker, rec therapist, and the physician is kind of in the background. So one other program I want to share, and I'll talk even faster now, this is called the Thrive program. This is one that does involve the physician directly, but also a whole other team. The lead here is Jackie Paykel, who's actually an OBGYN at Tampa, and who developed this program and is now spreading it around the country. It's been primarily offered to women. She's a women's health doc, and she started this program in women. But now it's actually being piloted in men, so we'll see how well the benefits that we've seen in women veterans translates over. So who is the team for this? The staff for this is a physician or an NP or a PA, a social worker, a psychologist, and then a number of guest speakers from specific disciplines. I'll show you who they are. This is actually a 14-week course. It's 2 hours each time, and every time they do it, they do mindfulness, they have homework, they usually do some movement, and they do that weekly for 14 weeks. This is the team, the physician, the social worker, psychologist. They bring in a pharmacist, they bring in a rec therapist, nutritionist. MOVE is a weight loss program in the VA, so they, at the different parts of the program, they bring in different practitioners. And it's really a team approach. And one thing that's really great is that this has been built as what's called a group medical visit. So when you talk about sustainability and the ability to pay for it, this actually allows the visit to be, quote, billed or counted as a physician visit, but because it's a group experiencing all at once, they get a lot more out of that physician time, but the physician also gets, quote, workload credit for leading a group. So it's a very powerful sort of model for how this can be financially sustainable across VA. These are the goals, also aimed at employees and improving their experience. These are the core components of the model. It includes positive psychology, acceptance commitment therapy. That's a common theme. This is very popular in vets, partly because there's so much, quote, moral injury where the meaning of their life needs to be presented in front based on the challenging memories and experiences people are dealing with. So, and it builds in mindfulness, exercise, etc. So just a little bit about their data. They've had data on 160 people so far, although this is spreading rapidly. And you can see the before and after improvements in depression, anxiety, satisfaction, and neuroplasticity, which is about sort of the ability to respond to change and stress. So really, again, impressive results. Dr. Paykel just recently went to New Orleans and trained a group of practitioners there to bring this to the New Orleans VA. And really, there's a lot of interest in spreading this around VA. One question I have is whether this is going to work in men. Obviously, you know, we have a lot of women veterans, and even if it works primarily in women, that's okay because we have a lot of women veterans in need of this. It's going to be interesting to see if the social support and kind of this group approach gets as high an uptake in men. Will the men really come through week 14, or will they get to week 6 or 7 and say, when are the women going to get here? And then, you know, perhaps drop out. That's the fear of the, and so they're actually looking at, is the 14-week model also right for men? I don't need to generalize about men, but, you know, is the 14-week model right? Is a shorter model going to be more effective? And so they're just now rolling out their first few groups in men veterans to see how effective that is. So again, just another example of how this is really an interdisciplinary effort. This one does happen to involve the MD. They're not, you know, they're just part of the team. And so this is really the way we think it should go, that it's a team sport and it sort of takes a village to make this whole health approach work. I'll stop there. Pleasure.
Thank you. I'm going to shift everything here just a little bit so I can see it along the way. Thank you very much. It's a thrill to be here and participate in this. I'm going to represent the perspective of the chiropractic community and the chiropractic component of this discussion. I'm going to try and drill down a little bit and get a little bit more narrow, as you might expect, as we move a little bit deeper into the discussion. The reality is we've got a tremendous gap, and the gap is killing us as a nation. And that gap exists between the knowledge and the materials and the information we have to work with and the practices, policies, payments, and the perspectives of the system. It's what we've heard talked about here for the past hour and a half. And all of these things are contributing to creating this gap. And the task that government has, the task that we have, is to try and do things that fill that gap in a constructive and productive fashion. You've heard other speakers this morning talk about the fact that we're transitioning out of an infectious disease management world into a chronic conditions-oriented world. We're also moving out of a provider-dominated world to a world that is dominated by lifestyle issues, that's dominated by genetic issues, dominated by the involvement of the individual. And we've seen the transition in patients from the patient who just does what they're told to the patient that's going to tell you what they're going to do and how it's going to be done. And ultimately, we're seeing the transition from fix to prevent. Some of the easy and low-hanging fruit for this discussion, the reality that we think about when we think of healthcare is we think about the things that kill us quickly and kill us in horrific ways. Cancer, heart disease, stroke, so on. These are the things that come to our mind most often. But worldwide, the #1 cause of disability is not cancer, is not heart disease, is not stroke. It's in fact spinal pain. If we take it a little bit further and we think about the moment that we're in relative to this pain, and we look at the overall world of chronic pain here in the United States and the opioid use environment that we're in right at this moment, we have a perfect storm that demands change and demands an end of business as usual. And we have an urgency that calls for new players, new practices, new strategies to get this done. Looking at the dollars and cents, imagine this, if you will. These are the 2010 data. In the United States, we spend $600 billion on pain. If we look at the cost that we spend on cancer treatment, the cost we spend on heart disease treatment, combine them together, and it's less money than we spend on pain in the United States. We're getting a not so good return on the investment, and we're getting an awful significant downside to the approaches and the treatments to that management that we are employing. 1/4 of all opioid prescriptions written in the United States are written for low back pain, when all of the guidelines from the Institute of Medicine, the CDC, the Food and Drug, the Joint Commission say don't do it. And if you do it for a day or two, maybe 3 or 4, but that's it. But instead that patient, as the general made reference to, gets that handful, that full bottle, and in 6 weeks they're addicted. We look at the IOM report, we look at the FDA report, we look at the CDC guidelines, and they have one thing in common: non-opioid approaches and non-pharmacological care. That's the order and the recommendation from the hierarchy of the system across the system. And we now have the opportunity to try and implement this across the board, as I said before, through practice, through policy, and so on, and in the perspective of the care that we offer. Now, for any of you that can read this slide, you're doing much better than I am based upon where you're sitting. But let me just jump to a couple highlights. This is an analysis that was published 3 weeks ago from the state of New Hampshire, dealing with the management of low back pain in the non-Medicare, non-Medicaid environment, based on 2013 and 2014 data. When chiropractic care is present, the costs are $1,513. When they're not, the costs were $6,766. A year later, the numbers went to $2,000 and $7,000. If we look at the opioid impact component, in 2013, when chiropractic care was available in this environment, the cost of opioids was $154. When it wasn't available, the cost of opioids jumped 4 times to almost $600. A year later, the same ratio, 200 to 900. The bottom line is we've had significant costs. If we look at what that data tells us, is that in 2013 and in 2014, there were 74% lower opioid costs, 78% lower clinical care costs associated with the use of chiropractic care. We take it down another year, and it was 78 and 71. The bigger issue is the lifetime utilization within our society of chiropractic care is about a quarter to half of the population. 8.4 to 14% of the population use chiropractic care on an annual basis, and the primary reason they do is for back pain and neck pain. But the important and the thing I'd like you to take away from my part of this discussion is the changes. This is from literature that was published less than 3 months ago, published in Spine, and it was an analysis of the National Health Interview Survey regarding the impacts of chiropractic care. And that the consumers that responded found that chiropractic care gave them a sense of control over their health, almost a third of the population that responded. It helped to reduce their stress level or help them relax, 40%. It helped them sleep better, 42%. It made it easier to cope with their health problems, 4 out of 10, and improved their overall health and well-being, 67% of that population. The general made reference to talking about the issues associated with mood, with activity, with sleep, and with stress. And I think if you look at that slide, it embraces all of those. I'm asking 6 things on behalf of my world in this discussion. We need to increase the budget of the National Center for Complementary and Integrative Health to fund the comparative research and systematic reviews needed to better understand the clinical and economic value of integrated care. We need to address the restrictions inherent in the Medicare system related to payment of various forms of integrative care. And we need to encourage the full implementation of non-pharmacological approaches in pain management. We need to expand the active duty military and veterans access to integrative care and have it provided by persons with the capacity and expertise in those disciplines. We need to appreciate and respect the feedback of consumer-driven information, such as the National Health Interview Survey, my apology for the slide error, related to complementary care, as I've illustrated relative to chiropractic care, and then ultimately support and implement the spirit and intent of Section 2706 of the Patient Protection and Affordable Care Act. Thank you, ladies and gentlemen.
Thank you. Hello, my name is Emily Telfair. I'm a naturopathic doctor practicing nearby in Baltimore, Maryland. And I'll be sharing with you an introduction to naturopathic medicine, which may be new to some of you, and also helping you understand the perspective we would take in addressing chronic pain by addressing the underlying cause. So to begin a discussion of naturopathic medicine, it's important to remember it is actually in our nature to be well, and that we are an integral part of nature. What happens is that disease occurs when we forget this. And we're in a healthcare system that systemically has forgotten that it's in our nature to be well. So naturopathic doctors are physician-level trained healthcare providers who emphasize disease prevention and patient empowerment to help restore health and improve vitality. And we do this by addressing the underlying cause of disease and illness using low-cost, minimally invasive therapies as much as possible. And our training occurs at one of 5 naturopathic medical schools, which is a 4-year postgraduate medical training with a strong foundation in the basic medical sciences and learning traditional diagnostic techniques and naturopathic therapeutics. And it's a 4,100-hour training program that includes 1,500 hours of direct patient care. And what I love about this profession most is the wide toolkit of therapies available to naturopathic doctors, since our core training includes diet and lifestyle therapies, clinical nutrition, herbal medicine, homeopathy, hydrotherapy, and we even learn physical medicine techniques. So applying this to an individual with chronic pain, the approach naturopathic doctors take is at first we want to listen to the whole story, because in that story are the clues to why this acute pain went and became chronic. And then in the treatment plan, using a multi-tiered approach to reduce inflammation, to help restore balance to systems that have become stressed, like the nervous system or the adrenals, which regulate our stress hormones, and also addressing the concurrent mood disorders that often accompany chronic pain. And then, of course, wanting to welcome in a team approach, as we've been discussing here, and remembering the importance of closing the loop and addressing practitioner self-care, because if the person healing the patient is also in pain and hasn't addressed their own issues, that's going to impact how they support the patient clinically. So I get curious when a person comes in with pain. What is underneath? Because pain is the symptom, but understanding the cause is just as important to know how to address treatment. So I'm looking for, are there structural issues going on? Is there an infectious component? Or does the person have an autoimmune disorder? But what I most often see is underneath there is trauma. Underneath there is fear. There's holding on to wanting the past to have been different. And this links to what Dr. Chesney referenced earlier, the relevance to addressing adverse childhood experiences for individuals with chronic pain. I have seen this repeatedly, not just with pain, but other chronic illnesses in practice, that the early experiences of unpredictable stressors and losses that people face in childhood are predictive for chronic illness in adulthood. And if they go unaddressed, then we've really not been able to treat the cause. And research continues to reflect this, showing how these early childhood traumas link to inflammatory pathways developing early in life, that when subsequent traumas develop, that the person's way more susceptible to developing pain and for it becoming chronic. So this graph further illustrates that when initially we have some acute stresses, the body might be able to bounce back and go into the green or homeostasis quite easily. But when those stresses persist, our mechanisms for regulation start to fail, and those stress hormones start to become, the cortisol levels go down and we become exhausted. So the treatment plan begins with calming down that inflammation and those excitatory messengers that get set up when there's been injury. So we may use herbal therapies. I frequently use homeopathy, especially before and after surgeries, if we want to be on that preventative end of minimizing the need or the amount of opioids where people can often initially become addicted. So arnica is a good friend in that regard. I often use nutrition to also help manage inflammation. And then building resiliency to stress. There's actually a whole class of herbs called adaptogens, which literally help our body adapt to stress. To go back to that green section in the graph earlier, to come back to homeostasis. I even use different nutrients like magnesium or B vitamins to also nourish the body. And the one modality I've seen work more than any other in treatment is that of mindfulness. It is available to us all the time, and it's free. And it is one of the most powerful tools to actually help a person shift their relationship to their pain. And I'd like to end with a patient story. This is Dr. Joe Strauss, who is an osteopathic physician, an orthopedic trauma surgeon, and a captain in the U.S. Navy. And he came to me several months before his initial deployment to Kandahar, Afghanistan in 2009. He was suffering from very severe anxiety and chronic headaches. And here he was getting ready to deploy and go into a trauma center in Kandahar. So in his, we addressed his chronic inflammation, his anxiety, and what later became known to be his post-traumatic stress disorder from multiple experiences of ACEs in his childhood. Some of the things he told me he'd only told one other person in his whole life about, of traumas that he'd experienced. So we did some good work before he left, and when he came back, and for over the last 8 years, we've continued to address his trauma, and now he has a whole toolkit of therapies that he's able to use, particularly mindfulness, he says, was most impactful. And he says that through naturopathic care, he was able to reconnect with himself as an individual while feeling fully heard. And he really, when I talked to him recently, he said, just let them know it's all about the love, because that's really where he was able to arrive back to within himself, and how that has transformed his ability to care for others, because he's still a trauma surgeon. He's still serving our country in the Navy Reserves. And if we aren't helping to heal the healers, again, we've really missed the boat, because he's somebody who can prescribe opioids. And if he's not able to manage and address his own pain, that can highly influence how he treats others in pain. So the opioid epidemic is in front of us. And through this quote from Mary Oliver, I'll end with, I don't ask for the sights in front of me to change, only the depth of my seeing. We all see what's in front of us. An opioid epidemic, which is really reflective of the chronic pain epidemic. But from this discussion today and learning about all these modalities, we see that between practitioners and policymakers, we can really help shift and increase access to what patients have available to them for treatment. So thank you for your time.
Last but not least, my name's Bill Reddy. I'm a nationally certified acupuncturist, and I also serve on the board of directors of the Integrative Health Policy Consortium. And today I'd like to assert that acupuncture can really be a major part in combating both the opioid and the pain crisis in the United States. And so just a little about the infrastructure of what we have is that there's 34,000 practitioners across the nation. We have 60 accredited medical schools that teach acupuncture. And in terms of the U.S. News and World Report, the top 5 hospitals in the country currently have acupuncture services offered. However, it's more outpatient care. It's not like they offer 60 acupuncturists, like, not Georgetown, let's see, Johns Hopkins University has maybe 3 acupuncturists. So we're growing, and Dr. Kligler already mentioned about the VA, so I'll continue. And so we're distributed across the nation. You can see that the red states are the ones, the dark red, have the most acupuncturists, of over 1,000 per state. And this is a little bit, I wouldn't take pictures of it, because California, I know, have about 8,000, but this particular reference has about half that. But it does give you an idea that there are some states that we really don't have a whole lot of acupuncturists in, such as West Virginia or North Dakota, and others like Florida and New York and California do have quite a few of us. So in terms of how we do, as far as the studies of acupuncture, is that there's over 7,000 studies when you type in PubMed, and over 27,000 studies on acupuncture in terms of general conditions that we treat. And that in terms of being more effective, there's a study where they did a meta-analysis of using opioids for chronic pain, and they said they don't really recommend it. Acute pain, fine, but chronic, not so much. And that's where acupuncture is really, really powerful. And also you can see that when acupuncture is used, there's a 60% reduction in opioids. So again, we can really be part of the problem. We just need to be implemented, and we need to have regulation to allow more insurance coverage. Now, as of now, we are at a essential health benefit in the Affordable Care Act in 6 states. That means 100% of insurance companies cover us. But in other states, basically people who can pay out of pocket will have our services and no one else, and that's wrong. And also something that we deal with the pain side, but we also deal with the addiction side as well. And there's a group called the National Acupuncture Detox Association. It's been around since 1975 is when they started using this protocol in New York. And at this time, there's 23 states that use it. There's over 40 countries that use this protocol as well, that uses auricular acupuncture, and it's a 5-point protocol. Very, very effective. And instead of just talking about pain, I'd also like to point out that the NIH and the World Health Organization did look at the studies. This is about 30 years ago, and you can see that everything from neurological issues to ear, nose, and throat, emotional conditions, we treat quite the gamut. And the cost is very reasonable as well. This is a few years old, but it indicates that about $75 is the cost of a treatment across the nation, which again, isn't really outlandish compared to a knee replacement, which is about 45 grand. And so the AHRQ have done a study that looked at surveys for 2 years at 89,000 acupuncture patients. And what they found was that 96% of the respondents said that they would recommend their acupuncturist to their friends or family. So that's pretty strong. And 99% said that they reported good, very good, or excellent service. So I think that that's just really outstanding in terms of just what we have to offer. And acupuncture is incredibly safe as well. It's been in the country for over 50 years. Well, actually, licensed, it's kind of spotty. We currently are licensed in 45 states. So we still are growing. But not one person has died in the past 50 years from acupuncture. And in terms of the adverse events, no real serious injuries have occurred. So what I envision is really an acupuncturist just being part of a patient-centered care model where we're working together as a team. We can have a chiropractor, we can have an acupuncturist, we can have a naturopath at the table along with the physician, and that way we can let the patient choose what they feel is most comfortable for their care. Thanks for your time.
Before I call up our phenomenal executive director for IHPC, Susan Hager, who I asked to take an interim role 2 or 3 years ago. She's done a wonderful job. So what you've heard today, you've heard several words, and this is just an introduction. It's very exciting that this caucus will be ongoing, that we're planning the potential of other briefings, more in depth about various clinical topics, environmental topics, advocacy, and policy topics. You've heard about integrative health. Please remember, integrative health is the best of conventional and other, not necessarily alternative, but other ways to look at illness as well as health and healthcare. You've heard about a team approach. It takes a village. Well, the team approach is very important. I'm going to be audacious to say, and I think I can as an MD, it's not about a hierarchy. It's not about a hierarchy. It's about people coming with humility, with their different disciplines, and bringing the best that they have to the patient in a very equal and pluralistic fashion. It's also about the opioid crisis. And again, it's not about the opioid crisis. We are having an epidemic of people that are suffering, that have lost their way in the journey of life. They have pain and they have emotional suffering. That is what we should focus on. Of course, the opioid situation, overuse, abuse has heightened this because people are dying of it. We have to focus on this, but we need to remember, in order to achieve 3 words for our healthcare system, we need to approach this as the pain crisis, not just the opioid crisis. Those 3 words that I would like to ask you to focus on, guide your visions, pray on, is a healthcare system in the United States based on prevention, wellness, and well-being. Thank you. Susan.
Thank you, Len. Thank all of you for coming today. I apologize that we just ran out of time to be able to do any Q&A. We have to get out of the room because they have to reset it. We will, however, there's materials on your tables, information on the Integrative Health Policy Consortium. There's also a postcard. On the front of it is a URL, especially for congressional staffers, where there's more resources and materials that you can go to. Our website is also linked there. So we appreciate you so much in coming. The speakers will move out into the back of the room and into the hall, and contact us through our website if you need more information. Thank you so much.